This idea of palliative care as being a soft science focus on things that people don't care quite so much about I think is patently false. In fact, I think the things we worry about are the things that most individual patients and their families are worried about.
Hello, everyone. We are live with my friend, Dr. BJ Miller, and the Muffin Man, the cat in the picture. How is everyone doing? Dr. BJ Miller, how are you doing?
I'm doing great, Ryan. Thank you very much. Good to be here. Hi, everybody.
Hello. Shane says, cat. Oh, my God, the cat. All right. Apparently, they're here for the cat and not for us. So
I totally get it.
That's all we need. That's awesome. So, Dr. BJ Miller, we're going to be talking about hospice and palliative care medicine. Mm-hmm. Let's talk about that. Well, I want to do a little bit of Q&A, a little bit of conversation. We'll jump into a little bit of a slide deck, and we'll have lots of time for Q&A for everyone later. How does someone who wants to go to medical school, it's like the far majority of students want to go to medical school because what they see on TV is blood and guts and saving lives in the emergency department and whatever the TV show of the day is for physicians. How does one go from, I want to save lives, to finding this passion to helping people overcome, or not overcome, but get through some of the most difficult times in their life?
Well, I mean, I think one answer to your question, Ryan, not narrowly, is like even if I were sort of addicted to that ER interventionalist, like, that is exciting. Sure, cool.
Yeah.
But of course, we know that doesn't always work. And so knowing that doesn't always work, I was interested to know, well, what happens to those people for whom it doesn't work? What happens when our interventions don't work? What happens when we're not fixable? And that really lit up for me as a disabled person. I'm not fixable. I work around it. I work through it. I deal, So I as I went through medical school, I thought I was going to go into rehab medicine, PM&R, physical medicine rehabilitation. But I realized I was much more interested in what we do around things that we can't control. I was interested to know what do we do when things fail, when we're abandoned by the interventionalists. Then what? So, and that's just been much more interesting to me, and it feels underdeveloped in healthcare, and it's much more relevant to me just personally in my own life. So that's how it kind of lit up. And I was going to get out of medicine altogether until I discovered palliative care, and then away I went.
For someone who doesn't know your medicine journey, talk about that journey of wanting to become a physician, kind of the path that you went down, and then finding palliative care, this kind of pivot point for you.
Mm-hmm. So I was injured in college. I had electrical burns sophomore year of college, screwing around on a commuter train. So that was I had a big brush with death there. I mean, I was, it was very touch and go and all that stuff. And I was 19. Then I ended up being a trilateral amputee. One arm below the elbow, both legs below the knee. And so that was my personal sort of introduction to death, the idea that like my death, not just death and this abstract thing. But more than death, it was more my entree into directly sort of really having to adapt to life in a big way. And so end of life was interesting to me as a piece of the puzzle, but it was much more, I was always more interested in just the general thing of what do we do with things we can't change or can't control. So then I went back to college, I switched my field of study to the arts. I studied art history because at the time, kind of as a newly disabled person, I was really reckoning with issues of identity, like who was I? What does it mean to be a human being? Am I less of a human now? Am I, what am I? Who am I? And studying art and thinking about the creative process and why human beings make things from the raw material of their life. That was very inspirational to me and very relevant to me. So I studied art, learned how to see. I developed perspective. And then it was a matter of like, what do I do to make a living? What do I do as a job? And then medicine lit up as a place where I could use these experiences. I just thought of like, gosh, if my doctor walked in as an amputee, what a different experience that would have been for me. And so both seeing the strengths of healthcare and its ills, I was similarly turned on to the whole thing by both. Um, and so went into med school, kind of on a lark. I went back and did the post-bac pre-med thing.
Mhm.
And then I was like, well, it was wasn't a very inspired decision. It was more like, gosh, this would be an interesting job. I think it would be relevant. My experiences as a patient would be relevant, I thought. Because think around disability now, it's not something that we used to talk about someone overcoming their disability.
Yeah.
You used that word earlier and caught yourself. I mean, it's overcome. Like, I'm not going to
Yeah.
overcome my body. Like, it's my body. I deal with it every day. And no, so rather the sort of newer thinking on disability is that you own it, you work with it. It's just who you are. And it's a source for creative imagination, not just, oh shit, I'm less than my body. My prostheses are these poor approximations for the things I lost and blah. No, it's much more free and creative than that. So anyway, so medicine was a way for me to use these experiences. Fine. I didn't know if I could do it or if I'd like it. So I just said, well, I'll start. If I'll either not be able to do it or I'll find something else I'd rather do. And then so down the way I went, I figured I'd work in a rehab setting, work with other people who had traumatic events, because I wasn't interested in medical science for its own sake. It was more to be helpful. And then deep in med school, I went through my sort of disillusionment period where the idealism that you bring into medicine often has to be checked against the realities of the system and practicing it. And that can be pretty hard. Yeah, can be a very disillusioning, hard moment. And so I was going to drop the whole enchilada. And then my dean at UCSF talked me into doing my internship year as a better place to stop. Do your internship year. You can become a GP if you want to. It's easier to jump back in. I said, okay. I went back home to my parents in Milwaukee at the time, did my internship at the Medical College of Wisconsin, and there did an elective on palliative care, just sort of on a lark, and fell immediately in love with it, in a day. And away I went.
Awesome. Away you went. Thank you for that story. Students love the stories. Let's go ahead and jump in. You said you had a slideshow that we can check out and see Mr. Muffin. Muffin Man. So
everybody, the slides are these are high level sort of food for thought. It's sort of, I wanted to start with a little grounding around what the heck palliative care is, because I'm sure most or all of you guys have heard of it and maybe think you know what it is, but I can't tell you how much we struggle in this field to define ourselves and describe ourselves. So just ground us a little bit in what the heck palliative care is, and then some sort of lessons learned from doing this work and sort of some of the frame shifts I think it invites and why it's a different kind of animal within the healthcare world. And just prompts and food for thought. And then hopefully I'll not ramble too much and then we can get into dialogue together. So this is just fun still from the movie The Seventh Seal. A man bargaining with death, which is always interesting. Okay, so again, forgive me, you guys probably all know this, but let's define palliative care. This is from CMS. So I'll just let you all read it and shut up for a second here. So, all right. So that's a kind of a mouthful, but you can see, I mean, first of all, for starters, nowhere here is death mentioned. Palliative care often gets conflated with hospice and end-of-life issues, and that's a big, big problem because obviously people don't want to talk to the palliative care guys because that means they're dying, or people wait too long to talk to the palliative care guys and suffer way more than they need to because of this misunderstanding of what it does. But look, by this definition, I've seen patients in my palliative care clinic at UCSF for 10, 12 years. So there's nothing about death that palliative care needs you to be dying anytime soon to get it. So that's one huge point. Please remember that. You're going to bump into that misunderstanding all over the place, including by doctors and nurses within healthcare. So a second big point here is this idea that it revolves around suffering. So that's a very importantly, exquisitely different notion in healthcare. Why? It was because suffering is subjective. There's no test for suffering. I don't get to tell my patient that they're suffering. They have to tell me. So right out of the chutes, there's this embrace of the subjective realm, whereas the rest of healthcare is sort of so hell-bent on objectification, which is important, has its place. But of course, life plays out in the subjective realm. And so palliative care embraces that. That's not a problem for us. That's something to be celebrated. Individualism, style, personality. Those are interesting and to be protected, not to be forgiven or put to the side. The other great thing about this subject matter is, who hasn't suffered? I mean, it is about as universal a human experience as you get. So here again, everyone is welcome into this mix, including us clinicians. We bring our own suffering to this mix. Yep. And then the other thing to note here in that first paragraph is patient and family-centered care. So the rest of the healthcare, the family is often sometimes really just in the way. But in palliative care, whatever's happening for the patient, of course, is colored by culture, traditions, their own experience, their family, and all of that becomes relevant for us, right? And then the last thing to note is in the second paragraph is all these other domains. Let me cut to this slide, which kind of puts us here. I mean, when suffering is your subject matter, no one discipline has a lock on it, right? So this work is inherently interdisciplinary, which as you guys move through your training, I mean, I think that's a really important piece of medicine. Doctors kind of rule the roost and get all the attention and credit and blame. But the truth is we don't act alone, especially in palliative care. The subject's too big. We can't do all this by ourselves. We need a team. Yeah. So there's all these different ways.
Good question. A good question that came up is how is suffering different than pain?
Great. So suffering, there's a couple different ways to answer that. So suffering is, you might say, is a sort of a human response to pain, or is pain sort of a stimulus, a signal. But suffering is how you might have two patients who have the same diagnosis, diabetic, neuropathy, and sort of solve for all the differences, and you can research these people and put them side by side. And one guy has this in stride, and another guy is just at arrears, can't think straight, is despondent, etc., is just miserable. So the one guy who's suffering, that pain is threatening their identity, is threatening their sense of self. Like, who am I in this world? I can't think straight. I can't find meaning. I can't find purpose. That's suffering. So pain, I have pain now. I mean, early on, 5 years, 6 years, my first few years as an amputee, I had all sorts of pain, and I suffered because I hadn't quite accommodated the fact of my life. I was at odds with my life. I was at odds with myself. And that's a good way of defining suffering. Yeah. I think of it as a wedge, a gap that opens up between the world you want and the world you have. So you can narrow that gap of suffering by, like, sort of the Buddhist contemplative way. You can quit wishing for a world you don't have, or you can change the world or change your reality. I think most of us humans do a little of both.
Yeah.
So that's the answer to your question. So suffering is much more personal. It's multimodal and has a social, intellectual, spiritual realms, etc. It's much more thorough. Yep. Does that answer your question, Ryan?
1,000%.
Okay. So, and then to keep moving here, guys, and I added this little logistical suffering in the lower corner here because I think we need to call out the fact that sometimes, despite our best interests or best efforts, healthcare can sometimes become the source of the suffering, not the fix of the suffering. And we suffer in logistical ways. I mean, the biggest complaint at UCSF is the shitty parking. So people are having these crazy experiences, life-altering experiences, and they come out and their car's been towed, or they're late because just little things like this, which affect your day, they're not so little. They totally affect the experience. And so big, little, we suffer from our logistics and from our short-sighted systems. And healthcare is a big, big piece of this problem as much as it is the solution. So need to call that out and be honest before that. So why is that? How do we end up with this healthcare system that is equally wonderful and helpful and equally horrifying and vexing? There's a quick medical anthropology. We can go back to mid-19th century. This is a painting of the ether moment in 1846 when ether was used to put this guy to sleep, and they operated on him freely. And, those of us who had surgery, thank God for anesthesia. It was a big moment, wonderful moment. But this is mid-19th century technology, industrial revolution, and science and medicine got in bed together. and objectification, the scientific method, the rigor that we all experience as a randomized controlled trial, et cetera, those became the dominating forces. And innovation, we were going to invent our way through every medical problem. And in a lot of ways, we've done that. We've done pretty well in some ways. But we're also starting to see the fallout of what happens when you separate the diagnosis from the person, the personality from the body, which can be sort of nicely summarized in this idea of putting the person to sleep so we can just focus on their disease. And in medicine, that's just true enough. We are focused on the disease, much less the person living with the disease. And that's a problem. That's a problem in all sorts of ways. We can talk about that. So 170 years into this mode of thinking, this mode of being, we're kind of coming to terms with the shortcomings of it. And palliative care as a field comes along to help kind of fill the gap. Because let me just go back for a second, guys. Think about it. If you look at this definition, I mean, on some level, shouldn't we just be able to cross out palliative care and put in healthcare? I mean, why isn't all of healthcare do this? Yeah. I mean, even if you're, trauma surgeon, most interventional, of course, aren't you doing this so your patient doesn't suffer more than they need to on some level? So again, these aspirations of medicine and the realities of medicine, in the gap between the two, palliative care is trying to fill it. Okay, so that's just a quick hit of kind of how we got here. So since 2006, the palliative care has become a subspecialty. It's now officially called Hospice and Palliative Medicine. That's the name of the subspecialty, but a relatively new one. So one of the things, so here's these prompts coming up here, guys, are just some lessons hewn from this work. All right. So one is this idea of quality of life. I mean, that's the, we say things like, if you have your health, you have everything. But the truth is, no, you don't. I know plenty of people with perfect health, great cholesterol, no, whatever, don't meet criteria for depression. And they're lost, aimless, miserable. Yeah. Health is not the same thing as the absence of disease. So in some ways we talk about quality of life. It's like a consolation prize. Like I've been in zillions of conversations where, the oncologist says, I'm so sorry, Mr. Smith, we can't cure your cancer. But we can go for quality of life, like it's this consolation prize. But the truth is, of course, from me as an individual, never mind across a population, but quality of life is the much bigger prize. I mean, I care about having my health insofar as I can use it to have a quality of life. Yeah. So this idea of palliative care as being a soft science focus on things that people don't care quite so much about I think is patently false. In fact, I think the things we worry about are the things that most individual patients and their families are worried about. This is just thing, like, we're pathology focused. People show up in healthcare usually because something's gone wrong. There's a problem. So our job in some ways to make them help them suffer less, to make life less bad, less hard. That's a big mission. That's great. But I also think for our own sanity's sake, we have to keep an eye on where in our practice we can help life be more amazing and more wonderful for people. That's not a cue for each of us to somehow do even more. It's more of an invitation for you to bring your style and your smile and your bedside manner to the mix, not as a nice aside, but as front and center. Because of course it colors the experience for you as a clinician as well as the patient.
How much of your own experience being an amputee do you think helps you with these conversations, helps you with language like that? I have a daughter. I think when we talked last time, I talked about my daughter who has a genetic condition and she uses forearm crutches to get around. She turns 7 on Saturday. And so I'm constantly thinking about this type of language, and she's old enough now. She's asking questions, and she has a 2.5-year-old brother who's jumping now. And the other day she wanted to jump too, but she can't without her crutches. And so she was talking about it and she got a little sad. I'm like, well, you just do it differently, right? Everyone has something going on. It's just different. How much do you think your own experiences play into that? And how can someone who kind of subjectively we would go as an able-bodied person can have those same kind of conversations, and how can they bring the empathy to the conversation to help?
Yeah, brother. Good question. I mean, so I, in a way, have been lucky in that my injuries were dramatic and profound enough that they really taught me some things. They're not in the abstract. I mean, they really affected my life, and they didn't end my life, but they affected my life enough that I had to make some big changes. And I'm lucky insofar as that my disability is obvious. My patients know the second they see me. They didn't even have to ask me what happens. They just take one look at my body. And so one response here, Ryan, is that I'm grateful for that. I mean, that's allowed me to get to a place of trust with patients and families, I think, much faster than I would have otherwise. And in part because it's taught me just by my own experience, sort of the exquisite nature of language and identity, and how does one come to reframe their life? How do you frame life so that you belong in it? Mm-hmm. That's an exercise for me that wasn't theoretical or academic. That was very real. And I like to think it shows in how I care for people. Now, but what? So do you have to go lop off a limb to get? No, of course not.
Hopefully not.
You may need to, in terms of just for your own sense of owning your own suffering. But I would challenge you to think through, even if you're able-bodied, there's still a huge range within able-bodyism of things that go wrong, big or small, where life just doesn't go like you want it. Your body doesn't do the things or look the way you want it. So the stories may not be so dramatic or obvious, but if each of us is in touch with how hard life can be for us to kind of inhabit our own reality, I think any of us has access to those difficulties if we're really looking, if we're really honest. So I push each of you to own your own suffering. It doesn't need to be so dramatic, but plumb it. Apply it. It's a bigger teacher than any of your textbooks. And it's going to be the way you find yourself to empathy and nuance with people. Yeah. Does that answer your question a little bit, Ryan?
Of course. Yeah. It's empathy, right? It's coming to the conversation knowing that your experience is not the only experience, period.
Exactly. And I would say I'd add to that, and knowing that your experience is by itself still of value.
Of course.
So yeah. I will say, I think that needs to be said for part of the population like myself, I was raised very privileged. I went to Princeton, white guy, crude teen, blah, blah, blah. I had on paper, but I was a pretty melancholy kid. I was really confused by how the world worked and the way we treated each other and the cruelty that humans have, blah, blah, blah. I was deeply sensitive kid, even though you would look at me and think I had no rights to suffer, right? I had on paper, had it all. And so then I had this amputation thing happen. And you know what? I'm much the same person. It's just that something big enough, bad enough happened to me that people are willing to give me a little bit of credit, and I'm willing to give myself a little bit of credit. Whereas before, I would not have thought that my thoughts mattered, that I hadn't suffered enough. So I think part of the admonition to each other here is, yes, empathy, dare to put yourself in the shoes of others, dare to know that your experience isn't the only one, and own that your experience is still valuable and important and real. Both will help you.
Love it.
So great. So great questions, Ryan. Keep them coming. So here's just a slide to say there's much more of this shooting match that we're all in besides language, besides words. Body language, of course, is a big deal. But, this happens. I see people with advanced directives. We love it. If you can articulate your wishes, then maybe you have a chance of having them honored. But the truth is, I've dealt with so many people who have advanced dementia, and they couldn't state their wishes, but they'll pull their feeding tube out and be very clear about that, stop eating and be very clear about that. And yet somehow we don't honor that as real communication because they didn't say it. I guess I just want to turn our attention to the world beyond words because it's a big one. And also because in that zone, I also will be in the same breath would be pointing you towards your intuition, and is developing a clinical sense of service. You're going to need your intuition. And as you go through medical training, of course, a lot of it's intellectual. You're ramming words and concepts into your brain. Fine. It's important. Good. But at some point, if you're not careful, we'll start overriding your own gut sense of things. And I just want to name this so you guys protect your intuition, protect your gut, and you develop that alongside your intellect along the way. Speaking of wordlessness, this is just a nod to Florence Nightingale. And this book I love this book. So she was around late 19th century technology, industrial revolution, all the same stuff going on around the ether moment. But if you look at her writing, she talked about, the power of fresh cut flowers, the power of natural light. She talked about essentially about this word, the aesthetics of life. And aesthetics is a powerful therapeutic domain that is completely underdeveloped in healthcare. So let's quickly name it. Aesthetic is just the world of perception, the felt world, the smell, taste, touch, all that good stuff. And when you're talking about the body, I mean, why am I psyched to have a body? Why do I care to have a body? Well, it moves me around the planet, but it feels things. It takes the world in. That is monumental, primal value, a deeply valuable piece of the living puzzle. So I want to turn your attention to that. So, because otherwise we kind of assault the senses in healthcare, which is a shame. In fact, we have an antonym. We have a whole field called anesthesia, where the goal is numbness. So on some level, you got to help people. If we're going to take people apart, you got to help put them back together again. And one of the ways you put people back together again is through their senses. So it needs way more development than it has in healthcare currently. Curing and healing. Well, this is a good palliative care concept. I mean, curing, awesome, great, wonderful. It's so sexy. When it can happen. The problem is it can't always happen. And for everybody, eventually it can't happen at all for everybody. At some point we are incurable. So right now we've got a healthcare system that more or less leaves you with the statement, I'm so sorry, there's nothing more we can do to cure you, but there's more we can do as human beings to help you be comfortable, to give a shit about you, to accompany you, to bear witness. And that points us to this bigger goal of healing. So healing, the root is just whole, being whole. So I may be incurable, but I can be healed. I can be dismembered, but I can be whole. I can be dying and I can be healed. I can be whole as a person going into my death. So I want to call out, curing's great, but don't stop there. Care beyond the cure, and this gets you into the world of healing and wholesome, helping someone, facilitating their feeling whole, intact as a person. That's big, beautiful, mysterious stuff. And it also really relies on the patient to participate. Versus for curing, most of the job of the patient is to sit still. For healing, we really need them to engage. We need to engage them. So it's much more, our job as physicians much more becomes accompaniment and advocacy more than fixing them. Meaning so good. Like we're meaning-making machines to human beings. Depending on your belief system, we either find meaning or
That's some landmark language there. Meaning-making machines. Yeah,
well,
do you know
the
landmark form?
I think that's what est used to be. Is that right?
I believe so. Yeah.
Yeah.
I did it. I did it in 2019. Changed my life.
Well, interesting.
Yeah.
Well, so you're a fan.
I am a fan. Yeah.
Cool.
As soon as I learned that, my wife and her whole family has done it, and I was going through a rough patch, and she's like, "Go do the form." And so I went out to San Francisco like that weekend and did it, and fixed a bunch of relationships, and really just changed my perception of how I make meaning out of everything.
Oh, beautiful.
Yeah.
Oh, great. I'm glad to know that. I should look into that. Meaning is a very powerful force. I learned a little bit more about it from Viktor Frankl, Man's Search for Meaning. Yeah. I point everybody on this call to that book. It's a short read, it's powerful, and it really gives you some structure about how human beings make their way through hard stuff.
Yep.
So meaning is a big, big thing. This is the world of existential concerns, existential crises. An existential crisis really is a crisis of meaning. And those are not just for neurotic people or people at the end of their lives. I think the pandemic is introducing most of us, or many of us, or all of us, to the idea of an existential crisis. It's really a crisis of meaning.
Yep.
It's not for the faint of heart. It's, I think, actually an essential human experience is to have some sort of an existential crisis because you learn so much from it. So helping your patients, and my guess is existential crisis is probably the number one diagnosis in any clinician's office. It just doesn't get called out. We don't work with it. We think somehow our job as clinicians is not to help people make meaning, but to fix their bone or whatever else. But all of that is happening on behalf of meaning for the patient. So you can try to opt out of being involved in meaning making with your patients and families, but good luck. You can't avoid it. So I'd much rather everybody here kind of own it and roll with it, work with it. So great. Meaning and power, purpose, really stunning stuff. Really good stuff. And I also want to call out the power of meaninglessness. Like I can't always find meaning in my life. I certainly don't have answers to a lot of big questions, but that doesn't keep me from trying. That doesn't keep me less interested. I mean, in fact, there's something quite gorgeous about meaninglessness, because that kind of puts us in view of this. This is my slide for mystery. We don't know everything. The smartest person on this call will tell us we don't know everything. That's just the way it is. So especially if you want to be with your patients through to the end of life, you better have some relationship to not knowing, to mystery, and you better be able to hold that place with some confidence. Not knowing or mystery is not the same thing as ignorant. And, in medicine, we don't make a lot of space for mystery. We should. It's a really powerful force for curiosity, for discovery, for humility. So I would encourage you guys to find meaning in your lives and purpose and work with that and repurposing yourself over time as things happen to you. But I would also make a lot of space for all the things that you just don't know and learn to be inspired by that rather than flattened by it. So these next three slides are quick hit on, perspective making, essentially. And one way and another, you're going to be called to help people make perspective. The same with meaning, how to see, so how you've got a parent losing a child, or you've got death in the family, whatever, some big thing going on. And the way they've been seeing themselves in the world, this is nothing but hell. This is nothing but horror. But over time, you can help people change the way they see the world and change the way they see the world in such that the crisis becomes a source of learning. Loss becomes a source of appreciating what you have, etc. So working with perspective, this is a human talent we have. We can't change what we see in the world so much, but we can change how we see it. And that is a singular talent we humans have, and it's really something to be worked with. So this is an example. There's a picture, picture of the Earth from space. Amazing. And in this view, right, in this frame of reference, we're all one. We are on one thing. This is one world. We are one. We're part of this one thing. Or you could zoom out and you could look at that same world in the context of other planets and other stars and cosmic debris. And then we're one of many, right? Or you could zoom in. These are little virus particles. You could zoom in and then our
no
body...
virus, please.
Sorry. Yeah, PTSD on this call. But, right. And then all of a sudden you can zoom in on any little piece of a human body and you realize our body is a universe with trillions of critters on it. So all three of these images are accurate. They're all true. It just depends where you place your lens. And we as human beings get to zoom in and out. We get to frame things. So keep that in mind. It's a very powerful tool for your own sense of self in this world, but also helping others deal with things. Last couple slides here, guys, just some plugs for like a sort of an ethos in this work. I think I would encourage you all to get very, very good at noticing. We're built to see contrast, but so discern, see differences, see everything, look hard, pay attention. Yes. And on the receiving end, it's amazing to be seen. I don't think we have a higher job than bearing witness, but I think we can screw it up real fast when we let our human penchant run away with itself. And then not only do we see differences, distinctions, we then label value and judgment on them. We can't help ourselves to hierarchize something's better or worse. Well, see if you can fight that instinct a little bit. Yes, apply your ability of discernment and stop short with the judgment. You will be a happier person and your patients will love you. It sucks to be met with judgment. It's wonderful to be met with discernment. Big, big difference. Here too, the power of impossibility, huge deal, guys. Medicine, we market ourselves, we take on sort of godly powers. The public wants us to be godlike. We hate to say something's impossible, but the truth of the matter in this life and one person's life, there's plenty that's just not possible. And that is not a failing. On some level, that's a relief. At some point, your patient's going to be tired enough of this planet, of this life, that they're happy to let go. They don't need one more treatment to try, even just for theatrical purposes. No, there's something really wonderful about something being impossible, because when something's impossible, we're innocent. we don't message as well with our patients, so we keep sending them the signal that there's more that can be done. And then, of course, they end up feeling like a personal failure that they're dying, like they screwed up. They didn't respond well to treatment. They failed treatment. That's what we say. I mean, it's pathetic. What a lame. So we castigate poor dying people. Not only they have to die, but they have to feel like they're failing. So let impossible things be impossible. There's relief in that. That's okay. Another thing here is just watching our language. Whenever you put the word the homeless, the poor, the dying, you're saying, I'm not that. It's a rhetorical trick right out of Heidegger. You're saying, I'm not, I might care about the homeless, but I'm not of the homeless. Similar to say, like, I care for the dying. It implies that I'm not dying. But this one, guys, we all are. We're all in this boat together. And so let this be a lesson. One of the ways that life becomes so hard is through separation and alienation. And we keep finding ways to separate ourselves from others, to distinguish ourselves. But we suffer from that kind of separation. So just watch it. Watch, don't over-separate yourself. Don't over-distinguish yourself, because ultimately we are human beings and we are interdependent. There's no human being who's ever walked this planet nor ever will, my guess, who is truly independent. That is, who truly needs nothing from nobody, right? So cop to that. That's lovely. That's okay. That's not only, it's not failing. That's wonderful. We need each other. Think how lonely and miserable you'd be if you didn't. And this is really important to get this in your bones, because right now, I remember when I became disabled, I felt like, oh shit, I've got to leave the world of the independent people and go over to that ugly nursing home corner of the world of the dependents. The truth is, we're all on the spectrum of somewhere between total dependence and total independence. Everyone is always on that same spectrum. We may move around on it over the course of our lifetime, but it's the same friggin' spectrum. So don't accidentally send signals to people that they're that they're a different species now, or they got to go to a different planet, or they don't belong. It's one of the ways we're so subtly cruel with our patients. Okay, guys, that's it. That's it. I will just say this. How are we doing on time, Ryan?
We are doing well. If you want to come on and ask some questions, go ahead and raise your hand. While I get some people on, it takes a second for them to raise their hand and come on. BJ, a lot of students have asked about the kind of death with dignity that is becoming more and more, I don't know if popular is the right word, but we have a few states now that have passed death with dignity laws. From a hospice and palliative medicine standpoint, where does that society kind of stand with death with dignity?
So, yeah, good question. There's a lot to say about it, but I'm going to try to take a narrow answer to your question to start, at least. So the field officially was against the law for a while. It's interesting. It may be a little counterintuitive, as was, by the way, the disability rights population. Two groups that I would have guessed would have been for the law, because in so many ways the law is about self-actualization and autonomy, and it's my life. I get to say when it ends. But you start thinking about it from a systems point of view. A lot of the early concern was, if we send signals that, I'm too exhausted, I can't work anymore, I'm too much of a burden, I'm too ugly, steroids have made me swell, whatever it is. If we send signals to each other that, yeah, gosh, that sucks, you're right, you should die, let's get you off the planet, versus work harder to create a society where people won't feel the need to hasten their own deaths.
Yeah.
So there's a concern about a slippery slope, et cetera. But my field has evolved to the point where now it's more or less officially neutral. It won't get in the way of this legislation. It also you won't hear the field advocating for it either. So we're kind of neutral. But I will say, as a physician, I am generally for this law. It's got its problems. We can talk about it, but individually you'll get different answers. But as a field, we've been skeptical and now neutral.
Interesting. All right. Thanks for that. Pearl, why don't you unmute yourself and ask a question?
Hi, can you hear me?
Yep.
First of all, thank you so much for doing this. Hearing your Nocturnus episode was kind of my first introduction into the world of palliative care. So it's really cool to be able to ask you a question.
Sweet.
I think the COVID pandemic has really laid bare a lot of the flaws in how our medical systems treat critically ill and dying patients. And I'm just interested in kind of hearing your perspective of what this has revealed about suffering in the medical system, and also what those of us who may be interested in this kind of more humanistic side of medicine, but who don't end up in palliative care, what kind of aspects of palliative care we can integrate into our practice.
Great questions, Pearl. Thank you. So let's, first of all, I think, what's laid bare in the healthcare system right now is the limitations of healthcare. I mean, a lot of people living with metastatic cancer or incurable, late stage organ failure, et cetera. As individuals, a lot of people have come to realize the limitations of medicine, but medicine hasn't really owned its limits. And as a system. And so I think now, it's clear. I think the public had casually kind of assumed, well, gosh, the medicine will invent a way through that. They can fix this, just sort of assume that medicine has it. Modern medicine's so amazing, blah, blah, blah. But so one thing is clearly no, there's certain things we just can't do. There's certain things we don't know how to do. In some ways, the limitations of the cure it, fix it mentality are laid bare. And in a way, therefore, the need for palliative care has opened up, and the field is on ascent. There's no two ways about it. I think a lot of people would have been skeptical about palliative care in the past are now much more ready to welcome it into the mix. So that's a big thing. I think it's also clear that we don't have the infrastructure to accommodate masses of people who need help, need care, but can't be cured. So hospice houses, non-acute care, post-acute care facilities, non-acute care facilities. We do acute care very well from an infrastructure point of view in this country. Once you're beyond the acute stuff, though, it's a quick fall off. Nursing homes are synonymous with a kind of hell for most people most of the time. So our problems with the post-acute care infrastructure, long-term care settings, that needs a lot of work. I think another thing that's laid bare is the need for caregivers. That's been a quiet 50 million caregivers in the U.S. sort of suffering quietly without support. That is clearly, I think most of us are aware that's a huge problem. And then lastly, I'd say in the education and training front that clinicians are it's very obvious now that we need way more training and communication. How do we talk to people that we can't fix versus just call the palliative care team? So I think the shortcomings of medical training are a little bit more obvious now as well. And lastly, or sort of related to that, is that it's a brutally hard work. That healthcare, being a doctor, has gotten harder and harder and harder, and that something's got to give. This is just not tenable. Burnout is becoming an epidemic of its own. So I think that's a little bit more obvious now. Whether we have amnesia and are so keen to kind of post-pandemic go back to normal, quote unquote, I hope we don't. I hope we all will pause, remember this pain, and let it force us to make some changes. It's a really big opportunity, and my terror is we're not going to take the opportunity. In fact, that we're going to snap back to the old way. I hope that's not the case. We'll see. So that's one answer to your question, Pearl. Sorry for the long one. But your second half is a really good one. So even if you don't become a palliative care specialist, in some ways, I get more excited about people I meet who want to be a psychiatrist or an intensivist or whatever else, but want to bring palliative care sensitivities to that work. Sort of, for my money, the sort of infiltration model is going to get us a lot farther than trying to train a zillion subspecialists as consultants in this work. If we get folks, the distinction here, we call this primary palliative care. So primary palliative care is the amount of palliative care training that anyone should have, no matter what field they're going into. We're trying to drive this deeper into med school curricula. We've got a ways to go. But so for you, if you want to do something other than palliative care, but bring these sensitivities, take electives in palliative care. There are sort of shy of a fellowship in palliative care. There are other sort of training courses you can do. The University of Colorado has a master's program. Harvard has a 1-year certificate program called PCEP, Palliative Care Education Program, I think it is. And there are others. And just also, finally, whether you find some structural way to bring this to your work, just personally, you can read about it. You can protect your humanistic heart. You're probably not going to have, your attendings aren't probably going to do that for you, but I would encourage each of you guys to protect your compassionate soul that you're bringing into this work. It can get chewed up and spit out if you're not careful. So whether you not find some structural structural support and mentorship, you yourself, Pearl, can protect this part of your interest and bring it with you wherever you go.
Thanks, Pearl. Shane, hello, our fan favorite. Everyone in the comments loves Shane. Shane asks a question every week here. Hello.
Hi, Shane.
Yes, thank you for having me on again every single week. So Pearl asked one of my questions already, so that was fantastic. The question about how you bring it into your care, even if you aren't palliative specialist. But related to that, I kind of wanted to expand on that. So if as palliative care becomes something that is brought into curriculum and made kind of a standard as, this is how healthcare should be, as opposed to this is exclusively palliative care, because I really do like that definition of patient-centered, reducing suffering. Do you see a future where palliative care as a specialty doesn't need to exist anymore, where everybody, all these physicians are already, have that as the core, and so there's no need for special training in that? Do you see that anywhere in the future?
Oh, Shane, I love that question. That's my personal fantasy. I mean, I lie awake at night looking into the sky, and I sit here and think about the day that this specialty can go away. Because like we're saying, at least in my way of seeing it, this specialty needed to become a specialty because the healthcare system had lost its way. In some ways, palliative care mentality is the oldest mentality, before we got so seduced by our technology. So yes, I do, whether how practical that is or just a lovely aspiration, I don't know, but I do live for that day where all of healthcare is colored by palliative care sensibilities, and we don't need the specialist, or we need the specialist or just for refractory cases or for education purposes, et cetera. Whether that's going to happen, what's that going to take? People like you, and this is why I love the infiltration model, not just becoming a subspecialist, but taking these sensitivities into other realms. If more and more folks do that, then after a generation, we're going to have a very different system. So I hope, my money's on you guys, and I'd love to help make this happen any way I can. But I do think there's reason to believe we could get there by revamping the system and the way we're trained.
Awesome. And I did have one other question. If you could talk a little bit about what it kind of looks like on the ground. I was curious, what are the kinds of patients who seek out palliative care versus are recommended at the last minute? Who, I guess a good way to ask is who is in your care?
Well, so it's interesting. I'm bumping up into this. So last year I left UCSF to start my own little shop. It's called Mettle Health, METTLE, Mettle Health. It's online palliative care counseling and coaching. We see caregivers, or most of our clients are caregivers, a lot of patients, and we also see some of our clients are clinicians who are burning out or want to learn have a place to talk out situations with me and other palliative care people. So have a look at that. But why did I invoke that? Not to plug it, but to say, wait, where was I going with that, Shane? Wait, can you remind me of your question?
Yeah. So what does palliative care look like on the ground for you? What kinds of patients do you see?
So in this realm, in the mental health realm, because it's self-pay, we haven't marketed yet. So I'm finding a lot of people who come to us who are predetermined. They've heard a podcast, they met someone else who had palliative care, but they've already on some level bought into the concept of palliative care. And I've been really interesting to see that, because I used to think it would be mostly college educated, white people, middle class, blah, blah, blah. But it hasn't been. It's been a real smattering of folks from all walks. So I think the model, the idea is spreading. But I still think we have most of our clients are people. It's still true. Most are coming at this, the worried well, the people who take the time to engage healthcare as a consumer and to advocate for themselves, et cetera, or have the time and the resources to do so. So most of the people coming to us have something of have self-advocacy or someone else looking after them. That's still true enough. So we've got a diversity and inclusion issue in the field. It's still a pretty darn white field. I'm really hopeful that more and more people are going to bring their own experiences, including their race and ethnicity, into this mix, and a sexual orientation, et cetera. And also that we're going to dig into the cultural lens as well. Once we've embraced the subjectivity of the subject, well, what conditions us in our experience? Well, our culture does. So this is where I've been interested in leaning out to the public and engaging the arts and all the non-clinical people who have something to do with how we experience life and how we experience death and how we suffer. So I'm long-winded to answer your question, but we've got a long way to go. The exciting thing is it's wide open, and I and others are trying to pry open the door a little bit to let others come in, not just clinicians, into this mix. So look for ways to collaborate with artists, look for ways to collaborate with philosophers, et cetera. Look for ways to write about and bring cultural issues into the mix. And I think over time, we'll start having a much more interesting, a much further developed and much larger field, casting a wider net.
Fantastic answer. Thank you so much.
Thank you.
Thanks, Shane. Before I bring James on, I want to ask a question. BJ, you talked about kind of our allure of technology potentially hindering this ability to help people move on with their life without this constant need to cure and fix and solve. How much do you think potentially the litigious society that we live in plays into that as well, where doctors are scared of repercussions of not doing everything possible?
I think it does play in, but I also think it's a false entry point for a lot. I think that the cover your ass, the CYA kind of mentality is real. And I don't mean to sneeze at. I mean, there is, the long-term care setting is really a mess in a lot of ways. And it's very hard to change given the regulatory burden. It's very hard to do the right thing. There's lawsuits all over the place. Anyway, so I don't want to dismiss your question. I do think, though, that the truth is that the public, most people are very forgiving. Our problem isn't, I think that the onus is on us to communicate better. And when we screw up, apologize. We know this. This is not an opinion. We know that people end up in lawsuits, not because something went wrong, but because their doctor was such a jerk how they handled it. That's why lawsuits happen much of the time. So I'd say we can worry about tort reform and other things like that. But first, let's do our job to communicate well, to own our mistakes, to apologize and make amends however we can. And I think once we do that, a lot of the lawsuits would fall away. And the other thing that's happening, and I'm excited that I hope this happens more and more, it used to be like someone would come in with an advance directive saying no intubation, all that stuff, and then the doctor would say, well, screw it, I don't want to get sued, so I'm going to intubate him anyway. Because the conventional wisdom, like, you're much more likely to get sued if you don't intervene, even if you've got an advance directive telling you not to. Now, increasingly, I think we're going to hear from people who are going to sue their doctor for intervening. Yeah. And I'm excited. I think that would be a good thing.
Did you not see my tattoo?
Exactly.
Yeah.
So I don't know. I don't have my finger on the pulse of tort reform or the legal world per se, but those are my ruminations on the question.
Yep. All right. And then last question here with James. Go ahead and unmute yourself, sir.
Hello. Can you hear me?
Hello. Yeah. Hi, James.
Hey, nice to meet you. It was nice. It was a good talk. It was very interesting. Thanks. I do have a quick question. It might not be super quick. Sorry about that. But it's actually about insurance. So I've been working in a private practice for a little bit over 6 months now. And I think one of the, banes of my provider is insurance. It's a lot of it. It's about when you file a medical claim, whether or not insurance finds it medically necessary. Depends on the CPT codes that we bill for with the correct modifiers. If things are not right, then they give us a big fat no, we're not paying for this. And then the provider is frustrated because she provided the service, but she's not billed for the certain, or she's not able to collect for certain things because insurance disagrees with it. And I think that brings a good question for hospice and palliative care, for prior authorizations. Are those typically required for a lot of these things? When you see a patient, are you thinking about which codes do I need to bill this patient for in order for me to actually get compensation for my work? I noticed that in mental health, your private business, you actually only do self-pay. So I kind of presume that you probably did have a lot of struggles with insurance, but that could just be me jumping the gun and saying that. But and I know and it's not like fair to compare you to like psychiatry, but psychiatry, another one of those kind of hard to really concretely define. Like you're not seeing like these signs and symptoms in these patients, right? When you're billing, it's hard to prove on your chart like, oh, this patient actually does need these services. So how do you, or as a provider, did you feel frustrated when you worked with insurance? Did you feel like a lot of your care was dictated by insurance? And did you feel like, like maybe your work wasn't fairly compensated or anything like that, which led you to more of a self-pay model?
Yeah. You're right. This is not a short question. not a simple question. But absolutely, insurance colors the experience of the practice of medicine in zillions of ways. Certainly, it colors the experience of being a patient, and it sucks. It's just gotten brutal. I mean, the clinic I worked in at UCSF, on some level, I was sheltered as a physician and in a big academic regional medical center, that kind of thing. I was sheltered from a lot of the headache. But I saw enough of it that it drove me crazy, and having my charts audited, and I had to go back and check the right boxes and blah blah blah, and it just really absolutely poached the experience of just trying to care for someone and do the right thing by someone, and it's gotten worse and worse and worse, very onerous. So this is where a lot of this conversation, this is is moot until we have some big time policy changes. Most physicians I know are, and increasingly so, are in favor of a single payer system because of this issue. So yes, it's a huge problem, and it colors the experience in ways it really shouldn't. And I feel for the payers too. They're applying the system that we have. I don't really feel for them that much, but I know they've got their own stressors. But the whole dang shoot and match needs to be revised. The whole way we do this is just crazy talk. And in palliative care, there's not a lot of there aren't a lot of codes for the things that we do, like existential conversations. Most of my conversations with patients, I'd have to bill for anxiety. I'd have to call them anxious. They didn't have anxiety. They were struggling to find meaning in their life. They needed to reframe how they saw themselves in life. Good luck finding a code for that. And yet that was what they really needed. And that did color their medical experience. So I had to kind of play a shell game and code for the nearest thing. And that's a big problem.
I was going to ask, I work in a specialist office. So a lot of the codes that we use are for like specialist visit codes, like a 99213 or 99214, or like new patient, we use a 99204. So I was doing some research just not too long ago. I was trying to figure out like what kind of codes do you actually use when you actually try to build these insurance companies? And when you did it, I assume since you weren't following the claims, like part of my job is also to kind of follow claims. And I mean, I see big fat denials sometimes just because we didn't check this box this way, or we didn't do this way. So and I think I work at a specialist clinic where it's like, actually we have charts and like good signs and symptoms to actually prove to insurance companies like, hey, we actually did this patient had these issues, and we can see it documented in the chart. But like you were saying with the existential dread conversations, like, what are you charting? Like, oh, this patient was really, like struggling with his life and could not really find out where he was in his life. So what codes did you use? And I guess, do you know the CPT codes? I'm just very curious because it's very
I can't
mind-boggling
remember the codes.
To me.
Well, is 9913, 9914, because ultimately what we would often do in palliative care as an MD or an NP, that's another big problem. Chaplain and social work, huge pieces of the puzzle in palliative care. They don't have a billing mechanism. But putting that aside, that's a big problem. But what I would do as a physician, I often billed on time. I can't remember the code numbers. I don't remember if 9913 or 9914 gets at this. But if you spent greater than 50% of your clinical encounter counseling the patient, you could bill on time. And that was the magic code for us.
Okay.
It would allow me to bill for my time. But then if I were billing for an intervention, a medication or something like then you run into trouble because you don't have a code for existential distress. I could get my encounter covered.
Okay, but not the care, like the procedures that you would do.
Exactly.
Or if you were trying to prescribe a medication, they would get pushed back and you would need prior authorization or trying all these 50 other different meds before you try this one. Okay, that makes sense.
All of the above, yes. And the truth is, in palliative care, we're little, most of the time we're oftentimes helping people do fewer interventions.
Right.
So we're not. So in some ways, palliative care, we make it work, but it's so flawed. It's so imperfect. And yes, for me, starting mental health, one of the joys was to sidestep the medical system. So I didn't have to keep an electronic medical record. I didn't have to worry about insurance. And it was just the most pure hour of direct human contact I could create. Another conversation I can tell you about our plans at mental health of how to grow and find other ways to get paid. So it's not on them to pay the bill all the time. But it was but my starting mental absolutely on some level was a demonstration against the practice of medicine. And then the other thing behind it for me was, I'm interested in the non-medical pieces, the philosophical, spiritual, much more than the medicine stuff. So as in mental health, I'm coaching and counseling people to use their doctors, but I'm not becoming their doctor. So we are technically a social service, not a medical service. And that allows us to work around the system in other ways too.
Do you mind if I ask one quick follow-up?
We got to go, James.
Okay, I'm sorry.
That's all right. Thank you, James.
Sorry about that.
gotta respect BJ's time. BJ, thank you so much for your time. I appreciate you as a human being. I appreciate you as a physician. I appreciate you as a mentor. So thank you so much for sharing your wisdom with the community. So many students talking about how this was the best session by far, and just wiping away tears listening to you talk. So I appreciate you so much.
Thanks, Ryan. And thank you, everybody. You're beautiful. You're great questions. And hang in there. Medicine is amazing. It's got a lot of challenges. I hope you'll stick with it and bring the rest of you into this mix. Bring the rest of yourselves into this mix. There's a lot of creative work to be done. So hang in there. Reach out to us at Mental Health if we can help with anything. But thank you, Ryan.
I appreciate it. Have a good night, everyone. Thank you, BJ.
Bye, guys. Bye. Take care.